So no disclosures here. So in the next hour, what I'd like to do is focus on 5 objectives. First, to recognize the growing population of adults living with congenital heart disease. And then we're going to use the format that the board recommends to do these topics, develop some key points about transition of these patients, recognize the comorbidities that exist. And to do that, I'm going to focus on several of the late complications in specific patients, and then understand the maternal cardiac risk factors for adverse events in pregnancy and touch on contraception options, something we didn't think about a lot in pediatric cardiology, but is coming up more and more and could definitely be an area of focus. So when you look at the content outline from the American Board of Pediatrics, for the initial certification exam, adult congenital heart disease is going to comprise 5% of your test. For the recertification exam, 6%. And there's only 5 topics that they ask you to know, and they're listed here. So transitional care, pregnancy, cardiac risk of long-standing systemic disease, collateral disease with long-standing congenital heart disease. That has been on there for years, and I'm never quite sure what they mean, but I'm going to point out 2 specific situations with collaterals, and hopefully that'll cover it. And lastly, psychosocial issues. So let's get started. Why are we dedicating this amount of time in this review? Well, we know that children are living well into adulthood with congenital heart disease. And you can see several epidemiologic studies here that are saying by the year 2020, there will be more than 2.3 million adults living with some form of congenital heart disease in the United States alone. And when we look at those adults, it's interesting that you can see the breakdown of the types of congenital heart disease that people are living with comes like this, where about half of those patients have more simple forms of heart disease, such as septal defects or isolated valve disease. But the other half of that pie deals with more moderate or complex forms, and I've highlighted here some of the lesions we're going to specifically talk about. Now, the first point about transition is very important. Although we see children every day and their parents in the clinic, it's amazing what we think they know and what they actually know. So you may get asked this on the test. Congenital heart disease patients may not know their type of defect. They may not know why they're on certain medications or the impact of their exercise and limitations of exercise. They may not know risk factors for having endocarditis or that there's a hereditary nature to congenital heart disease. They also may not understand the risk of pregnancy and birth control options, and most importantly, the need for lifelong cardiac care. And this is something that in the past several years has really been emphasized through new research that we're going to touch on. There is data for this, talking about transfer to adult congenital heart centers. One of the earlier studies that was done out of Canada looked at patients transitioning from Toronto Children's Hospital, sick kids, to the general hospital, and they have to do that by age 22. So this was a study that looked at over 300 patients and how well that center did with transfer. So you can see the patients here, and less than half of them had what was defined as a successful transfer in young adulthood to the adult center. At least half had an unsuccessful transfer. Dr. Reed and colleagues were able to look at why that occurred and found that you were more likely as a child to have a successful transfer to an adult congenital center if you were an older age at the time of your last visit, if you had a greater number of surgeries, or, and most importantly, if there was documentation in the chart that you needed to be followed. And this is a take-home point. Write it down in the chart. There's newer data, which is, I think, the largest study to date, looking at new patients to adult congenital heart disease centers. And this was a collaborative effort funded by the NHLBI from the partnership with the Adult Congenital Heart Association, which is an advocacy group, and 12 North American centers that take care of adults with heart disease, congenital heart disease. And we identified that 42% of these adults hadn't been seen in at least 3 years, and 8% of them had not been seen for more than a decade. So this is a big problem in our society, and we were able to look at what was the reason why people didn't come back for adult congenital heart care. And in all groups, meaning if you had a mild form of heart disease, moderate or severe, number one reason was that people felt well. which is terrific. That's what we want. But those group of patients with complex heart disease, if you just look at those, many were not receiving any medical care at all. Think about the age group. People in that college age group oftentimes don't go to the doctor. Or they had lost their insurance, they had moved, or something financial prevented them from coming. So this is one of the key barriers that we recognize in caring for adults that have grown up with congenital heart disease. So when you think about transition, education, and timing, there are some guidelines. It has been proposed that beginning in early adolescence, as developmentally appropriate, patients should begin to understand and assume responsibility for their health care. And in fact, a formal transition process for patients with congenital heart disease should begin at the age of 12 years. Now, there's very few numbers you need to remember in this section, but that is one I would write down, star it, do whatever you need to. I was actually shocked when I learned that, quite truthfully, but that is the age that's recommended to start transition. As I mentioned from the research, a written transition plan is really important to have it documented in the chart about the importance of lifelong care. And then we, as practitioners, need to be able to communicate that both to the parents and to the patients, as they will be ultimately responsible for their care. Now, one of the examples on the content outline was to understand the psychosocial outcomes in adults with congenital heart disease, and there have been more and more studies looking at this. And we are recognizing now some of the neurocognitive events that take place in these patients, and it is true that behavioral, developmental, and neurologic abnormalities are significantly more common in congenital heart disease patients. In fact, some studies will say that over 50% of adults with congenital heart disease meet diagnostic criteria for a major psychiatric diagnosis such as anxiety or mood disorders. And when you look, again, it's not just in the patients that have a Fontan procedure. This is in all severity groups. And in recent guidelines, it's recommended that we refer these patients for vocational counseling and higher education counseling. And this can be very helpful to do early to try to identify these deficits. Now I'm going to focus on some specific comorbidities and start with the worst one, mortality. So this pie graph is from a registry study in the Netherlands that looked at almost 7,000 adults that were living with congenital heart disease, and almost 200 had died. The median age of death was 48 years. And when you look at the causes of death, I think it speaks to what we see in the population is that we've traditionally thought that sudden death was a major cause of death, but that was only about 20% of this population. Heart failure complications were very common, shown here in blue. But if you look at the other complications like vascular and non-cardiovascular causes, this is just speaking to the fact that the population is now getting older and dying of other things besides heart disease. And I show you this data not to memorize any numbers, do not memorize these numbers, but this is a large registry from the United Kingdom which looked at almost 10,000 patients with congenital heart disease, they're in this column here, compared to almost 30,000 people without congenital heart disease. And literally every single comorbidity, whether you look at the cardiac comorbidities such as atrial arrhythmias, heart failure, hypertension, or non-cardiac comorbidities have much higher odds ratio in that congenital heart disease group. So now we're going to talk about some of these individually that I think your examination might focus on. Sadly, we now recognize that children that grow up with congenital heart disease have a higher chance of malignancy than the general population. This is some data out of Quebec, and in this figure, the boxes here are congenital heart disease patients who have a malignancy, compared to the circles are patients without congenital heart disease that's developed a malignancy. And adult congenital heart patients have up to a 2 times higher prevalence in both sexes of having a malignancy. The most common cancers would be breast, colon, and prostate. So now we're paying much more attention to exposures that children have that may contribute to this, but overall, this is something that we need to recognize and we need to screen for. Thinking about how people feel, it's long been known that adults with congenital heart disease do have a lower exercise capacity than patients without congenital heart disease. And this is an interesting study from the Royal Brompton. If you look, all of these patients considered themselves in New York Heart Association Class 1. They felt they were unlimited. But look at the variations you see in peak VO2. We had some really fit people up in the 40s, but we also have some people with peak VO2s that would be in a level that you would refer someone for a transplant, yet these people felt asymptomatic. So you cannot use New York Heart Association class as a marker of how people are doing. Giving you some numbers there. Basically, congenital heart disease adults reach about half the peak VO2 that then controls. And that's important because that number does correlate with adverse outcomes. Another comorbidity that we need to recognize is atherosclerosis. This is a study recently published out of Stanford looking at adult congenital heart disease patients. The mean age was about 37 years, and 70% of them had at least one modifiable atherosclerotic risk factor, most notably overweight or obesity or systemic hypertension. And when looked at, 30% of them had abnormalities in lab values that would point to this, meaning an abnormal hemoglobin A1C, HDL cholesterol, or C-reactive protein. This gave the population overall a 36% median estimated lifetime risk of atherosclerotic heart disease. So I think that oftentimes we're focused on the anatomy and physiology, as we should be, but we need to recognize in the adults this comorbidity and think about modifiable risk factors. Now, the next system to focus on when you think about comorbidities is the kidneys. This is again data from the Royal Brompton showing you that 1 out of 11 adults with congenital heart disease have some degree of low GFR, here in the blue or significantly low in the pink. And these patients have a 3-fold times greater mortality than the other patients. Renal disease is the leading predictor for mortality in our patients. And you can see in this Kaplan-Meier curve, those patients with the worst GFR in pink have much higher cumulative mortality over time. Going to the liver, we are just starting to recognize the complications long-term of liver disease, and this often affects patients' candidacy for transplant, so something to think about. It's been most studied in our patients with Fontan physiology. We know that with the Fontan circuit, adults can live with chronically elevated central venous pressures, and that's increasingly being recognized as contributing to both morbidity and mortality. This slide is just showing you the comparison between a normal liver stain, and with the trichome stain, you can see great degrees of fibrosis, sinusoidal dilation, and liver fibrosis. This is something that now we're starting to recognize in our patients. The next system, pulmonary disease. And I think it's important to just remember that adults can have a host of pulmonary problems. This X-ray is just showing you one of my patients who had a phrenic nerve injury when they were young, resulting in an elevated hemidiaphragm. This is something that can affect pulmonary mechanics. Diaphragmatic function is very important long-term, as are perfusion abnormalities in these patients, specifically those adults who've had branch pulmonary artery stenosis. If they have low perfusion to one side of their lung and the other lung gets something like a pneumonia, they can get in real trouble. There has been recent data showing a high prevalence of obstructive sleep apnea in adults with congenital heart disease, and this is probably one of the more under-recognized pulmonary problems. Restrictive lung disease, especially in patients who've had a prior lateral thoracotomy that may result in varying degrees of restrictive lung disease scoliosis. They can also have anatomic malformations of their jaw, their trachea, their airway. Sometimes just that big heart pushing on bronchus or other structures is going to cause pulmonary problems. And lastly, pulmonary vascular disease. I want to spend a little time on this because this is something that does come up. When you think about pulmonary hypertension in an adult congenital heart disease patient, there are several ways that they could have gotten there. And I like this classification system, which points out 4 different mechanisms for it. Firstly, you could just have post-operative pulmonary hypertension. The child may have had pulmonary hypertension before the operation and it persists afterwards. However, there are other adults that have more coincidental pulmonary hypertension, and that is they may have been born with a very small ASD that should have never caused elevated pulmonary resistance, but for some reason they may have some other genetic predisposition to have that, and they have coincidental PH. There are patients with left to right shunts that have mildly increased PVR but do not exhibit cyanosis. And then there are those patients that we follow with Eisenmenger syndrome, where the shunt is so large it is reversed over time. We're going to talk more about this. The bottom line is it doesn't matter how you got it. If you're an adult living with pulmonary hypertension, you have a much higher chance of mortality, much higher hospitalization rates, and much higher resource utilization rates compared to patients with congenital heart disease that do not have pulmonary hypertension. Eisenmenger syndrome is a rare complication of a large shunt that was not repaired. You can just see in the schematic here, initially in childhood, that flow was left to right, but that increased flow to the pulmonary tree over time caused changes in the vasculature and elevates both the pressure and the resistance, so the shunt will start to go bidirectional, where blue blood is now going into the red circulation and eventually may go mostly right to left, resulting in true cyanosis and Eisenmenger syndrome. These are patients which we need to be very thoughtful when we care for them because they have a great deal of long-term issues. And I'm going to, again, just focus on that multi-system involvement. I do think this could be a question on your test where you're asked how to manage these patients. Remember that when you have lower oxygen levels, you develop a secondary erythrocytosis and you can have hyperviscosity symptoms. These are headaches and leg pain and other things, and this doesn't always correlate with the hematocrit. Patients oftentimes with cyanosis have an elevated hematocrit, and they also will have iron deficiency anemia. And this is one place where in our laboratory testing, the MCV is not reliable. We have to check a transferrin saturation to see if they require iron. They can also have varying degrees of coagulation abnormalities, and this is one of those things that you recognize when you send off an INR. It has to be in a specific citrate-specific tube so that you get a real value. And then just when you think about these cyanotic patients, remember that there's abnormal cell turnover. So not only the red blood cells, but also uric acid, which can lead to gout, the bile acid, which can lead to gallstones, as well as renal dysfunction. Many of these patients have subclinical dysfunction, meaning that they may actually have a normal creatinine when you look at them. But after one dose of Toradol after a procedure, their creatinine could double because their creatinine clearance was less. So what you have to do is think about those things and be prepared to treat them. Now, as far as therapies, when you're dealing with an Eisenmenger patient, there's a couple things to absolutely know. The first thing is that pregnancy is contraindicated. There is a very high rate of mortality in these women, not only during pregnancy, but directly afterwards in the first several weeks, which is devastating. For these women, you should use non-estrogen form types of contraception. And because the board content outline specifically talked about contraception at the end, I'm going to go through a few slides for your reference, but that's the one to remember. If you have cyanotic heart disease, you should not have estrogen-containing components to your contraception. Treatment of hyperviscosity symptoms. So again, I think this is a testable question, and the answer is if someone comes in and they're cyanotic and they have a high hematocrit, the first thing to do is make sure they're not dehydrated and adequately hydrate them if they are. Additionally, you're going to want to check the status of their iron stores. And you can see here in red, I've written, do not use phlebotomy routinely. And this is based on the 2008 Adult Congenital Heart Disease Guidelines that says phlebotomy is only indicated to treat severe hyperviscosity symptoms in the presence of a hemoglobin greater than 20, hematocrit greater than 65%, once hypovolemia has been excluded. Okay? Now, I'm pleased to tell you that those 2008 guidelines were recently updated, and if we're lucky, they may even come out tomorrow, okay, for the 2018 guidelines. That will not be on your test, but something for your practice that you'll want to look through after your test is over. All right, now let's go into some specific lesions that you'll see in the adults. And I'm taking these basically off of that content guideline, but I think what you just have to remember is that advances in care have led to different long-term complications in patients depending on when they were treated. And of course, repair does not equal cure. So again, that take-home message for lifelong care. Now, I'm going to start with patients with tetralogy of Fallot because this is indeed the largest group of adult congenital heart patients that we care for. And there has been a real evolution of surgical repairs. Initially, in the 40s and 50s, they were primarily palliated with a shunt. And here's just an example of several types of shunts that could have been placed. The classic Blaylock Taussig shunt, which took down the subclavian artery to the pulmonary artery to provide a constant source of pulmonary blood flow. BT shunts are usually done on the side opposite to the way the arch branches, so this is a right BT shunt. More commonly now, we do a modified BT shunt where you don't disarticulate that subclavian artery, but put a graft down from the subclavian to the PA. Other types of historical shunts you'll just want to know are the Waterston shunt, which is the ascending aorta to the RPA, or the Potts shunt, which is a descending aorta to the LPA. Now, when patients undergo complete repair, these shunts are taken down, but these are hard shunts to close, so patients may end up with residual shunts and elevated pulmonary vascular resistance in those lungs. So then, after you do the palliation, they went through what's called a stage repair, where the goal was to close the VSD and open up the pulmonary outflow tract. And since the mid-1970s, really now, we try to do primary repair and don't do as many shunts. But when you look at the data on long-term complication of adults with tetralogy, it's going to depend, again, on what type of operation they had. Because there's many types of complete repair. And you guys know these. They could have a transannular patch where the surgeon has literally cut across the pulmonary valve to relieve the pulmonary stenosis, which leaves them with free pulmonary regurgitation, and they close the VSD. Patients may have had a conduit from their RV to their PAs. They may have had a valve sparing procedure like an infundibular resection, or in about 15% of patients that have the most severe form of tetralogy with pulmonary atresia, and their pulmonary blood flow is primarily by aorta to pulmonary collaterals, they may have had to have unifocalization of these arteries with a right ventricular outflow tract conduit. These are the patients that undergo many procedures in their lifetime. So I point out the word collateral there to make sure we know that with a tetralogy patient, there are aorta pulmonary collaterals that are going to provide, again, increased blood flow to the left side of the heart. That's going to be compared to other types of collateral vessels. I've listed here the late complications that we see in adults with tetralogy of Fallot. For a long time, we've really focused on the right side of the heart, recognizing that if you cut across the pulmonary valve and take away the integrity of it, you're going to be left with pulmonary regurgitation. And the good news is if you have to have one valve leak growing up, this one does pretty well. Patients don't seem as limited. But we now recognize that over time that contributes to RV dilation, dysfunction, and adverse outcomes. We also see patients with tricuspid regurgitation, whether or not it's from annular dilation when the tricuspid valve dilates, or whether or not for the older patients, they may have actually had part of their tricuspid valve septal leaflet incorporated into the VSD repair. So now they have an abnormal mechanism contributing to their TR. We can also see residual right ventricular outflow tract obstruction, and that can be really anywhere from the subvalvular level to the valvular level, all the way out to the branch PAs. Additionally, in those patients that have had a BT shunt, when it's taken down, they can have discrete pulmonary artery stenosis as well. But as patients age, we have to start thinking about other complications that involve the other side of the heart, like aortic dilation, LV dysfunction, arrhythmias, both atrial and ventricular, and sudden death. And again, this is the largest group of patients that we see, so let's spend a little time talking about it. I'm showing you real historical data because it seems to come up on tests quite a bit. What you have to remember is when you see an adult with tetralogy, there's a real electromechanical cardiomyopathy that is there. And the hallmark of taking care of an adult congenital heart patient is when they present with an arrhythmia, you look for an underlying hemodynamic abnormality and see if you can optimize it, okay? So this was the original data by Michael Gadzoulis looking at 178 survivors of tetralogy, and what he showed on this axis here is the QRS duration. All of the patients who had a poor outcome being syncope or sudden death, had a QRS duration on their EKG of greater than 180 milliseconds. So not too many numbers you need to remember for this section, but 180 milliseconds for a QRS duration in a tetralogy patient is associated with bad outcomes. And just to emphasize that, I'm showing you an EKG here of a typical right bundle branch block. It's blown up here in the corner, showing you a wide QRS, thinking about that electromechanical cardiomyopathy that's present. So let's think a little more about arrhythmias in tetralogy patients because these become incredibly common as people age. This is data that I'm showing you from the ARC group, which again had, this study had 11 North American centers looking at over 500 adults with repaired tetralogy. And what Paul Carey was able to show was that 43% of them had had either a clinically sustained arrhythmia or an implantable arrhythmia device or ablation at some point in their lives. This graphic is showing you the different types of arrhythmias. So AFib is in green, intra-entrant atrial tachycardia is in orange, the blue are shades of A-flutter, and then the red is ventricular tachycardia or ventricular fibrillation. And what I wanted to highlight here was, although in tetralogy patients we worry about VT and we worry about sudden death, it's much more common to have atrial arrhythmias as you age. But that's not to say that those atrial arrhythmias shouldn't worry us. They absolutely should. Here's some data from Taiwan just showing you in their registry of almost 5,000 patients with tetralogy, the prevalence of arrhythmias. And you can see in this group, just over 200 patients, about 3/4 of them had a tachyarrhythmia, 1/4 had a bradyarrhythmia, but you can see the mortality that's associated with these different types of atrial arrhythmias. Here, ventricular arrhythmias, even higher mortality, but don't forget about the bradycardic arrhythmias such as AV block, sick sinus syndrome, or tachybrady syndrome, where it was also prevalent and worrisome. Atrial arrhythmias in these patients are common. Moving on to the hemodynamics, thinking about ventricular dysfunction, as we see more and more adults, we're getting away from just thinking about the RV as the only problem. So this is a study from the ARC group looking at adults with repaired tetralogy, showing you that 1 out of 5 have at least some degree of LV dysfunction by echo. And in fact, when you look at their diastolic function, and this is hard to do because some of those markers weren't routinely screened for, but it's clear that adults with repaired tetralogy have both left ventricular diastolic dysfunction as well as right ventricular diastolic dysfunction, and those patients that have diastolic dysfunction have a higher chance of having a sustained ventricular arrhythmia. And we have known for a long time in patients with tetralogy that ventricular dysfunction is associated with mortality. Here's some data from Canada. It was a case-controlled study looking at patients who had died with an LVEF less than 40 and compared to the group who had an LVEF greater than 40. One of the things that stands out here is that the patients with the lower LVEF were operated on later. They had a shunt for longer, more palliation. But LV dysfunction absolutely associated with worse survival, and more current imaging data is showing us that these patients have abnormal strain that's also associated with these outcomes. So one of the take-home messages when you think about tetralogy and care for these patients is that their mode of death is actually changing as they age. Here was an earlier study from the Mayo Clinic showing you that in this group, about half of them died of sudden cardiac death. This was a single center study out of Germany, quoted a lot, looking at the mortality in these patients over time. And our more recent data showing that one of the major causes of death is everything else, but not the heart. Now, when you think about patients with tetralogy, one of the most challenging clinical questions that we get asked is, when should we replace the pulmonary valve and will it make a difference? And you can see that at least in the only set currently of adult congenital heart guidelines that there wasn't great evidence to support replacing the pulmonary valve. So what did the guidelines actually say, and what would be the question on your test, well, it would be reasonable for adults to consider pulmonary valve replacement if they have moderate to severe RV dysfunction, no numbers given, or moderate to severe RV enlargement, no numbers given. Or if they have symptomatic or sustained arrhythmias or moderate to severe TR and you were intervening on those as well, okay? Now, I just put together for you 3 different guidelines to show you the consensus for timing of pulmonary valve replacement. That first set of guidelines from the ACC and AHA was from 2008. This second column is the European Society of Cardiology, which was published 2 years later, and also the Canadian Society of Cardiology. And basically, the numbers are not always given, but ventricular dysfunction would drive your decision, as well as dilation of that right ventricle or other factors such as TR arrhythmias. So I've put that there. One of the things that we're starting to recognize is the degree of residual pulmonary stenosis or right ventricular outflow tract obstruction that can be a problem, but no one has the definite answer on that just yet. And why is this important? Well, as much as we convince our adults that have severe PR to undergo a PVR, there have never been data to show that it improves outcome with regard to death or sustained ventricular arrhythmias. And there was a recent meta-analysis looking at over 3,000 patients with repaired tetralogy. And I think it's important to point out that the reason we do it is because patients feel better for the most part. And you can see on this graphic that other things do also improve. Their right ventricular volumes go down. However, their exercise capacity does not really change. Their ejection fraction does not really change. And the LV volumes may increase slightly, but there's no direct evidence that we're making a huge impact on function. We know that it's generally a very safe procedure with a 30-day mortality less than 1%. But something to think about: what drives us to do PVR and when should we do it? I have just put together for you a small graphic showing you different investigations using cardiac MRI about when to consider putting in a pulmonary valve in patients with a repaired tetralogy of Fallot. So my recommendation would be, once the indexed end diastolic volume is above 160, once the indexed end systolic volume is above 85, or any degree of ventricular dysfunction, right or left. Because remember, putting in a valve is not going to get you better function. Okay, so now I just want to focus on a few other groups that you need to know about for your adult congenital portion. Transposition of the great arteries is another condition which the surgeries have really evolved over time. And these 3 graphics are just going to show you the different types of surgeries. So a lot of adults right now are living with the atrial switch procedure, known as a mustard or a Senning procedure. When you think about this, think about taking a pair of pants and putting one pant leg up to the SVC, one down to the IVC, and bringing the waist of the pants over to the mitral valve to get the blue blood to the left ventricle and out to the lungs. And this was terrific because this surgery created pink babies from being blue. That red blood comes back into the pulmonary venous atrium to the right ventricle, which then pumps out your aorta. So these patients are left with a systemic right ventricle. Starting in the 80s, it was recognized that instead of switching the inflow, you could switch the outflow. So this is a diagram of the Jettine procedure, the LeCompte maneuver, which brings the pulmonary artery forward. The surgeon has transected both great arteries and replaced them to the opposite route. In doing that, you also have to move the coronary arteries, which is going to be one of our long-term complications to focus on. Lastly, I just wanted to point out, when you see adults with transposition, there's a specific set that may have had a Rastelli procedure. Those are patients who've had D-loop transposition with pulmonary stenosis and VSD. And you can see the Rastelli procedure involves putting an RV to PA conduit and then baffling that LV back to the aorta through the VSD patch. So patients with Rastelli procedure now have a systemic LV. However, they do have other problems, and we'll get to that in a graphic in a minute. Just one example of a cardiac MRI in an adult living with transposition and atrial switch procedure. So in these short axis images, this is the hypertrophied, dilated right ventricle, which is dysfunctional. And when you think about these patients over time, many of the trouble that they get into results from that dysfunction. And there's been lots of theories as to why systemic right ventricles become dysfunctional. I've listed some of the theories here having to do with the underlying myocardial structure, the fact that there's trabeculations, and that the electrical system is not the same or robust enough to handle systemic pressures over time. So there's varying degrees of dyssynchrony. In pathologic specimens, we see a great deal of scar tissue that's developed. We can now use techniques such as diffuse fibrosis on cardiac MRI to see that fibrosis tissue within the right ventricle. And there is most likely abnormal coupling between the atria and the ventricles in these patients. One of the things that we're recognizing more and more is that those patients with RV dysfunction that have worse tricuspid regurgitation do worse over time, and you need to intervene early. So as a summary in thinking about adults with transposition, I find this table helpful, which I borrowed from Dr. Gava, just thinking about older patients that have had that mustard or Senning procedure, the atrial switch. They can have various problems with the baffles. They can be small and become obstructed, specifically in patients that have pacemakers. This is often a problem with the superior limb. Baffle leaks are also often under-recognized. When you think about a baffle leak in an atrial switch patient, just remember that it should act like an ASD, okay? So it's taking red blood back into the blue circulation, and what that will do is it will dilate that pulmonary left ventricle a little bit. So if you're an adult living with an atrial switch procedure and you look at an echo, that left ventricle should look very small, like a pancake. And if it's big or dilated at all, you're gonna wanna think about a baffle leak. Now, the right ventricle, because it pumps to the body, is where you're going to run into problems. There are varying degrees of right ventricular dysfunction in these patients and tricuspid regurgitation. Patients can also have some left ventricular outflow tract obstruction. Here it would be pulmonary stenosis. I want to tell you, this is not always bad. So there's some feeling that with that little bit of pulmonary stenosis, you're changing the configuration of the septum, which may be more favorable long term. So you don't always need to intervene on mild degrees of PS in these patients. But arrhythmias is another very common complication. When you do surgery in the atria when you're young, and then those atria dilate over time and become rigid, they're a setup for arrhythmias. Now, more recently, our adults have undergone the arterial switch, and as I mentioned in that diagram, because you've moved the arterial roots, you can have problems at the anastomotic sites. You can have branch PA stenosis, and this is oftentimes where the PAs are stretched over the ascending aorta. That neo-aortic root gets dilated, it gets regurgitant, and we have to think about coronary artery issues. And they may not present with classical CAD, but there have been studies using IVUS and other flow techniques showing abnormal vascular dynamics in the coronary arteries of people with arterial switch procedures. Lastly, that Rastelli procedure is associated with different problems. Remember, RV to PA conduits don't grow as you grow, so oftentimes those need to be replaced. They can be regurgitant. And just thinking about also the ventricular dysfunction is something that we see. Okay? One pearl, when you're looking at these patients with imaging, is that they may actually have their native pulmonary root still there, which can cause some subaortic obstruction. Remember, they've had an RV to PA conduit. Okay, now let's transition and talk about adults that are living with repaired coarctation. Just like the other two conditions that we've talked about, if you're an adult living with coarctation, you could have been fixed a number of different ways. And please remember that not all coarctations are as beautiful as it's depicted here in this illustration as just a tiny pinch narrowing of the descending aorta. We have adults living with coarctations who've had hypoplastic transverse arches, varying degrees of arch obstruction, and several procedures. Now, one of the older procedures that could have been done is a subclavian flapoplasty, where the surgeon takes the left subclavian artery and just flaps it down to the descending aorta. So if you check a left radial pulse in these patients, it would be diminished, similar to if they had a classic left BT shunt. However, they don't do that procedure anymore. We now are doing more end-to-end anastomosis if it's favorable. If you need to, you can extend it up to the transverse arch if there's hypoplasia. Historically, patches were also used, and those materials used for the patch can cause problems in adults. Specifically, Dacron patches often cause aneurysms. Lastly, patients could have had bypass conduits, and you'll see these adults where there's a conduit going from the ascending aorta to the descending aorta, just bypassing that area of obstruction. There are also people who've undergone primary catheter balloon dilation and/or stenting. This is often a reasonable option for adults for people who present in adulthood with coarctation. But there are many residua that we need to think about when we care for these patients. So this is just an MRA showing you some mild residual coarctation here and some dilation of the descending aorta below that. So coarctation is a vascular abnormality. It's not one simple anatomic lesions, and some of the complications are related to that abnormal vasculature. So when we look at these patients, we still look for any degree of residual obstruction and for aneurysms. At least half of the patients have a bicommissurial aortic valve, so they can have ascending aortic dilation, they can have aortic valve disease. We look for any other left-sided obstructive lesions. We look for left-sided hypertrophy because that has been associated with worse outcomes in these patients. Systemic hypertension is very common, often under-recognized. This is the one lesion in our adults that we take care of where there is absolute evidence where they get early atherosclerosis. This has been shown both in animal models as well as small patient series that patients with coarctation are at increased risk for coronary artery atherosclerosis. And then cerebral aneurysms are common. About 1 in 10 people who are born with coarctation may have an aneurysm in their brain. And I've just put an asterisk here to remind us that the guidelines actually say that every patient with a coarctation should undergo at least one brain imaging study to ensure that they do not have a large aneurysm in their cerebral circulation. So long-term complications in these patients anatomically, you can see in this MRA reformat, this is someone who had an original conduit placed that's quite twisty now. This is someone who'd had a Dacron patch graft and now has developed an aneurysm. And that's what you need to remember. The 2008 Adult Congenital Heart Disease Guidelines recommend cross-sectional imaging, so MRI or CT, at least every 5 years in these patients. A lot of these patients are followed by people who are not congenital heart specialists and don't know this guideline. So I point that out just to make sure that we're doing that. Now, hypertension is one of the most common comorbidities, and this is something that we should recognize and treat because it's going to affect their long-term outcomes. We've recognized now that being a vascular process, coarctation is associated with abnormal endothelial function, and many patients have increased arterial stiffness. So one study has even showed that up to 1/3 of patients have exercise-induced hypertension, and the question is, should we treat that? Well, here in this graphic is showing you those patients with exercise-induced hypertension definitely have a higher left ventricular mass to volume ratio, or LVH, and we know LVH is bad. So aggressively looking for hypertension in coarctation patients is important, as well as thinking again about those modifiable risk factors like smoking and high cholesterol, things that we really need to address because they have aortic disease. Now, the last group of patients I want to focus on as adults are those with Fontan. You can see this illustration here, one of the more classic types of Fontan, where the right atrium was basically put up to the PAs by a patch. We know that these patients suffer from a lot of comorbidities as they get into adulthood. And I've listed some of the more common ones here. Arrhythmias, incredibly common. Ventricular dysfunction or valvular regurgitation. Thrombotic events is a major area of study right now in our field. Patients can develop protein-losing enteropathy, hepatic and renal dysfunction, and many of them live with a more low cardiac output syndrome and varying degrees of hypoxemia. So I use this list to remind us that an adult with a Fontan should actually have a normal saturation when you see them. they should not have a low oxygen sat. And if they do, we need to think about what could cause it. And there's many things. So it could be that they were left with a fenestration simply to help provide some pop-off when the central venous pressures went high. Or they could have a residual atrial communication that wasn't recognized. Or, here's the collateral set number 2. They could have systemic venous collaterals, that's blue blood, connecting to either pulmonary veins or the pulmonary venous atrium. So those systemic venous collaterals are going to make you desaturated. Patients who've had a classic Glenn procedure where the surgeon has disarticulated the right PA and just to the SVC are at high risk for pulmonary AV malformations, which will also lower their saturation. And then there's all kinds of rarer things like unrecognized connections from hepatic veins that return to the left atrium, reopening of the levoatrial cardinal vein to the coronary sinus, or intraatrial shunting through Thebesian veins. Remember also when we talk about the coronary sinus that we don't often think about this, but some of these procedures like the atrial switch procedure or the Fontan procedure, you may end up with the coronary sinus in the red atrium, and that will also cause desaturation, and that's not something that you can fix easily. Now, when we think about these Fontan patients, we know they suffer from poor outcomes. And this was a graphic made by Paul Carey when he looked at several hundred patients in Boston who'd undergone a primary Fontan procedure. And you can see that the incidence of sudden death, which is here in white, happens quite early. But the longer-term complications, like heart failure, which is in pink, or thromboembolism, which is in blue, happen many, many years down the road. And we're still learning how to manage these patients. One of the, again, challenging questions in management is how to best anticoagulate an adult with Fontan physiology. So some centers feel strongly that all patients should be on anticoagulation, such as warfarin. Others use aspirin. You may find people that are on no prophylaxis. I'm going to show you this data to show you that at 20 years, if you're on aspirin or warfarin, there has never been a study to show superiority between the two. Although the numbers here are a little different, the p-value is not significant. And yet, you need to be on something. Because if you're not, your freedom from thromboembolic events at 20 years is basically 1 out of 2 if you're on nothing. Now, I'm going to caution you that those novel agents that we seem to be using more and more, you should hesitate before using those in a Fontan patient. And I say that because the HRS Society published guidelines for treatment of arrhythmias in Fontan patients, and they actually listed those as harm, class 3. Not to say that people aren't using them in practice, but for testing purposes, I would stay away from novel agents in Fontans. Okay. So in the last several minutes, I want to switch now and start thinking about things that we don't think about all the time in pediatric cardiology, and that's pregnancy. You will be asked pregnancy questions on your test. And I'm highly confident that you will know the answers, okay? Because all you need to do is think about the hemodynamics. And this is terrific because this is what we do all day. So when you look at this type of graphic, I'm showing you the duration of pregnancy on the x-axis and the change in hemodynamic values on the y-axis. So this first red line is going to be plasma volume. Women gain a lot of volume during pregnancy, up to 50% of their pre-pregnancy volume. But look at the timing of the curve. They're loading mostly in the second trimester and the early third trimester. So when you think about women with different cardiac lesions, you have to think about this type of volume loading later in pregnancy. Compare that to stroke volume. Yes, stroke volume goes up. It goes up to 30%, but it's often reached its peak when women are just recognizing that they're pregnant. Right here, 12 weeks, that's basically the end of the first trimester, okay? In a similar way, heart rate goes up, but that continues to kind of stay up during the pregnancy. It's estimated that women increase their heart rate at least 10% during pregnancy. However, those studies don't really think about patients who've had an atrial switch procedure, who probably have sinus node dysfunction and can't increase their heart rate that way. So that's our job to think about those things. Let's look at this next value. This is cardiac output. This mirrors the timing of stroke volume, but it goes up even higher up to 50%. And that, again, is just at the end of the first trimester. So when you're studying for the boards, you're going to remember this graphic because everything is above this baseline, except one thing, the systemic vascular resistance in green, okay? The placenta is the best afterload reducer in the world, much better than any ACE inhibitor or ARB, and that's why some women with certain types of congenital heart disease actually do pretty well during pregnancy, like regurgitant lesions. Pregnancy is not a problem because they're living at a low SVR state. But when you get to this point over here, when they deliver and in the early postpartum period, then there may be problems. Now, what could they ask you on your exam? Well, they could definitely ask you about this. Do women with congenital heart disease know about their risk in pregnancy? This was one of the earlier studies that was done out of Toronto, a very good, large adult congenital heart center, and Dr. Kovacs went out to the waiting room and basically gave questionnaires to all the women and asked them what they knew about their risk in pregnancy, and 37% of women denied that they had ever been told they were at any increased risk, and only 1 out of 2 remembered ever having heard about contraception from a cardiologist. Now, we know, based on multiple studies, that women with congenital heart disease are at risk for volume overload and arrhythmias during pregnancy, probably up to 15%, okay? And just recently, there has been a new risk stratification model. So you're gonna say, Anne-Marie, this was only published a couple months ago, this isn't gonna be on my test. Yes, it is, because the factors are the same. The high-risk factors are not hard to remember, okay? So if you have a woman that comes to you that wants to be pregnant and she's already had a cardiac event, they're at higher risk. If she has a poor functional class, New York Heart Association class 3 or 4, of course, she's at higher risk. Or if she has a mechanical heart valve, and I'm gonna spend a few minutes talking about the management of that because it's so important. So just so you know this, because you will see this data out there, the original risk stratification data was done in Canada, published in 2000 by Dr. Silverside, Dr. Liu and colleagues, and it was called the CARPREG data. They've now updated it, just recently published this, almost 2,000 women with heart disease, and the highest risk scores are those 3 groups. Other things you need to recognize as higher risk, for sure, ventricular dysfunction, high risk left-sided lesions like unrepaired coarctation or severe aortic stenosis, and pulmonary hypertension, and rarely patients show up with coronary artery disease. They're all higher risk. These last 2 are newer things in the model, which I don't think you'll be tested on, but just so you know, they found if you had not had a cardiac intervention, and that's basically you show up with heart disease, or you're late in your pregnancy when you show up, then that's higher risk, okay? But this is something that you're gonna find helpful in your practice as well. Now notice here, I'm not giving you any numbers as far as how much AS or how bad does the EF have to be. But the European Society of Cardiology several years ago published this document looking at the World Health Organization classification for maternal cardiac risk, and I'm just sharing with you class 3 and class 4. Now these numbers, again, are European guidelines, but I think they hold true. Women that are in class 3 or class 4 have greatly increased risk of morbidity and mortality. So just remember many of the things we've talked about: cyanotic heart disease, mechanical heart valves, systemic right ventricles or Fontan patients, and then varying degrees of aortopathy. The patients that should be counseled against pregnancy in their guidelines would be those with pulmonary hypertension, severe ventricular dysfunction. They're giving you an EF of 30. I would say that here we would counsel them even with EFs that are below 40. Severe aortic stenosis that is symptomatic, coarctation, and again, aortopathies, all risky. So just a point on valvular heart disease in pregnancy. This could be a question you get asked. And in general, stenotic valvular lesions are not as well tolerated as regurgitant lesions because of that graphic we remember and the changes that occur. So when you think about it, on the left side of the heart, mitral stenosis, as you go through pregnancy, the problem is your heart rate increases and you have less time to fill. So there's less diastolic filling time. You can get high left atrial pressures, and these women can go into pulmonary edema. So the classic therapy for that is control the heart rate. Aortic stenosis is another set of problems because women get increased cardiac output and they can have increased end diastolic pressures. Women with symptomatic aortic stenosis get into trouble in pregnancy. And there's recent data out of the ROPAC group in Europe that would collaborate with that. So now let's just focus for a minute on mechanical valves, because this is information you should know. This was originally published in the 2014 Valvular Heart Disease Guidelines for adults. But what I want to mention is that when you have a woman with a mechanical heart valve who gets pregnant, you have to do frequent monitoring, okay? And then unfractionated heparin is really a poor anticoagulant. It just has a very high risk of thrombosis. Vitamin K antagonists, such as warfarin, are safest for the mother by far, but they have an increased risk of fetal malformations. The complications of vitamin K antagonists are directly dose dependent. So here's the third number that you need to remember in this section: less than or equal to 5 milligrams. And that is, if you have a woman who's on warfarin and she has a therapeutic INR and her warfarin dose is 5 milligrams or less, she doesn't need to change that during pregnancy. Okay? Use of low molecular weight heparin requires meticulous monitoring of the anti-10A levels because valve thrombosis may still occur. And the data would show us that the majority of women in pregnancy that get into thrombotic problems get into it at the time of transition from a vitamin K antagonist to heparin. So we need to transition them prior to delivery because you do not want to do a vaginal delivery in a woman who's fully anticoagulated with a vitamin K antagonist because of the risk of a fetal bleed in their head. So if a woman comes in and she needs emergently to get the baby out, you need to do a C-section. This graphic I share with you just showing you those 2014 guidelines looking at the class recommendations for valvular heart disease for women with mechanical valves. So meticulous monitoring. If you keep the dose of warfarin less than 5 milligrams, you can do it throughout the pregnancy. If you can't, then change to a heparin product for the first trimester and then again at delivery. Okay, so in the last several minutes, I want to just touch on contraceptive options because that is also in our syllabus. I'm going to tell you that the next 4 or 5 slides are much more informational than stuff, something that you need to take to memory. But I'm going to talk about each of these options in brief. So the first one that we get asked about a lot is combined hormonal contraception, so the pill. And how does that work? Well, it inhibits ovulation, and it is highly effective if taken regularly. However, these pills that contain estrogen definitely have increased risk of thrombotic events, and they also really affect our endocrine system, so there's a potential for fluid retention, a potential for high blood pressure, and it also changes our cholesterol, so it can increase the LDL. So these are all things we have to recognize. And in fact, I've seen several young women with high blood pressure, and once I take them off their pill, their blood pressure normalizes. So I do believe this data is important for practice. You don't want to use the pill in women with cyanosis, with Fontans, or with mechanical heart valves. And it is strongly recommended that any woman with heart disease be on a low-dose estrogen, and that's going to be less than or equal to 35 micrograms. There are types of pills that are progesterone only. These have more side effects, so women don't prefer them as much, but they act more on the cervical mucus and they may affect ovulation to a lesser extent. So they're less thrombogenic, but they're higher failure rates. So you can either have injectable forms or implantable forms, but the side effects are not minimal. And that is you get fluid retention and breakthrough bleeding. And for those women that are on Bosentan, which is very important if you have a woman with pulmonary hypertension, that they are on a solid form of contraception, Bosentan may actually reduce the effectiveness of progesterone-only pills, okay? So we strongly encourage intrauterine devices that inhibit fertilization and implantation. These are very effective, and we do not feel there's an elevated thrombotic risk. However, there are case reports about women with Fontan having really serious vagal reactions when these IUDs are put in. So that doesn't mean don't put them in. That means make sure the person putting it in is aware and properly educates the patient beforehand about things to do to avoid a vagal reaction. Now, the other thing is we have to remind ourselves that these do not protect at all against sexually transmitted disease, and it actually is our job to talk to patients about that too. Other barrier methods with high failure rates are just listed here. And then, of course, permanent sterilization. So this is a really hard discussion when you have a young woman that has just transitioned to your care as an adult, and you have to talk about if there is a really serious risk of pregnancy, permanent sterilization. So I want to remind people that that includes tubal ligation as well as the Assure device, but it also can include vasectomy if they're with one partner. We do realize there's risks with these things, and this can be an issue if they have future relationships, but it's something that in certain women with pulmonary hypertension, with poor ventricular function, we need to recognize need contraception. So this is a nice graphic that Dr. Arwa Saidi from Gainesville put together, which I've borrowed, which just shows you those different types of contraception that I mentioned and different types of heart disease, what would be considered okay and what would be considered contraindicated, okay? And then the precautions here. So with that, I would like to leave you with just a couple things, changes you will make in your practice. So I think that thinking about adult congenital heart patients, you're going to develop a formal transition process with your patients at the age of, yes, that's right, 12 years. You're going to document a written transition plan in early adolescence and clearly state the importance of it, of lifelong specialized care, and then make sure to discuss contraceptive options and maternal cardiac risk of pregnancy in young women with congenital heart disease. So I've added a couple slides of summary just to emphasize those points that they mentioned in the content syllabus. So I'm saying these over and over because then we won't have to study anymore if you remember that the need for lifelong care needs to be emphasized, that there are multiple non-cardiac comorbidities that are associated with adverse outcomes, and specifically those cyanotic patients have multi-organ involvement, but please don't phlebotomize them. Late complications are common, but you need to know the surgical era that it was done, unique details about the patients, and a take-home point to really focus on modifiable risk factors: blood pressure, weight, lipids, smoking. Pregnancy and congenital heart disease. There are certain risk factors that have been established to be higher risk. I've listed them there. They're in that CARPREG 2 data as well. And lastly, estrogen-containing contraceptives should be avoided in patients with any thrombotic risk at all. Email me any questions that you have, and I thank you for your attention. Which of the following statements about transition of care for congenital heart patients is true? A formal transition process for congenital heart patients should begin by the age of 16 years. B, a written transition plan should be prepared in early adolescence and clearly state the importance of lifelong specialized care. C, the majority of parents of children with congenital heart disease have been counseled regarding the need for congenital lifelong care. D, documentation in the medical record of the need to establish adult congenital heart disease care is not associated with successful transfer of care. And E, at least 85% of young adult women with congenital heart disease have received counseling regarding contraception options. Please key in your answer. Fantastic. So I agree, wonderful, that the answer is B. And don't think that this is an easy question. This is the type of question that you'll be expected to know on your test, and that is true, and there's data for it. As far as why the other answers are wrong, we remember there's 3 numbers we need to remember. So transition's going to begin at what age? 12, perfect. And there has been data by Sue Fernandez and others showing that the majority of parents actually don't understand the transition process at all. They love their pediatric cardiologist. They never want to leave, right? So it doesn't make it easy for those of us that take over when something bad happens. So as you take care of the children that you see that are doing well, start talking about it. Documentation in the record, this is data over and over that's been published. You need to write it down. And at least from the Toronto data, only 50% of women with congenital heart disease knew about contraception. We're hoping that that's improving now, that there's more education. Terrific. All right, we'll go to the second question. In which of the following scenarios is the woman at highest risk for a maternal complication during pregnancy? A, 22-year-old woman with a bicuspid aortic valve and an aortic root diameter of 3.8 centimeters. B, a 35-year-old woman with repaired tetralogy of Fallot, normal ventricular function, and severe pulmonary regurgitation. C, a 34-year-old woman who is asymptomatic with a history of cardiomyopathy following a prior pregnancy and a current LVEF of 35%. D, a 30-year-old woman with repaired aortic coarctation in infancy with mild systemic hypertension. Or E, a 29-year-old woman who underwent an atrial septal defect repair at 18 years who has premature atrial contractions. You guys are doing great. So it is true that decreased ventricular function puts a woman at much, much higher risk than any of those other things. Now, none of those women are out of the woods, shall we say. Everyone should be seen by someone who knows about cardiac disease and pregnancy. They may develop some form of an arrhythmia or volume complication, but that's much different than going into a pregnancy with a muchly reduced ejection fraction where you're at high risk for sudden events or other real devastating problems. So remember that as the cardiomyopathies are a problem. Great. All right. Which of the statements concerning adults with tetralogy of Fallot repair is correct? A QR restoration on a resting ECG of greater than 160 milliseconds has been associated with an increased risk of sudden death. Atrial arrhythmias are the most commonly observed arrhythmias in adults with repaired tetralogy. C, the severity of pulmonary regurgitation can be determined by the intensity of the murmur. That is, the louder the murmur, the worse the PR. D, at least 40% of adults with tetralogy have some degree of LV dysfunction. Or E, there are evidence-based guidelines for pulmonary valve replacement that have been shown to improve long-term outcomes of death and ventricular tachycardia. And the correct answer is B, which the majority of you got. So those of you that answered D, good for you, because if we really look, there may be more than 20% of adults with tetralogy that have LV dysfunction, but right now the published data would be about 1 in 5 adults with tetralogy have LV dysfunction. But you're thinking the right way. Think outside the right heart. But the answer here that's most correct is going to be B. Atrial arrhythmias are the most commonly observed arrhythmias in adults with tetralogy. And just remember, that doesn't mean that that's not a problem. They are associated with morbidity and mortality. Why the other answers are wrong, let's just review. A QR restoration of what? 180. Number 2, that's our second thing we have to remember. And lastly, there really aren't evidence-based guidelines as of yet that show evidence that putting in a pulmonary valve replacement in repaired tetralogy patient results in better outcomes as far as death and VT. Other things, yes, death and VT, no. Okay, great. We'll go on to question 4. Oh, this is a wordy question. You know, that's the worst part of taking these tests is there's just a lot of words. So a 35-year-old man with unrepaired cyanotic congenital heart disease presents to the emergency room with headaches and fatigued. His medications are aspirin, furosemide, metoprolol, and fluoxetine. He's had some diarrhea over the past 2 days. He continued to take all of his medicines. On exam, his oxygen saturation is 75%, which he says is his baseline. His hematocrit is 63%. What is the best management plan? A, arrange for nocturnal oxygen therapy, as this has been associated with improved exercise capacity in patients with Eisenmenger syndrome. B, perform urgent phlebotomy to drop his hematocrit to 55%. C, emergent lumbar puncture. D, stop the fluoxetine and administer IV morphine. Or E, administer intravenous fluids. Fantastic. So we're going to remember that we never phlebotomize cyanotic patients. We always hydrate them. And that can be an issue because some of them suffer from volume overload. So it's a delicate balance, but do not phlebotomize them. Those other answers, although he has a headache, the headache is much more likely caused by hyperviscosity than it is by an infection. And answer A is interesting because I used to give people oxygen at night because I thought, why not? You know, that must help. But there actually is data that shows that it doesn't help Eisenmenger patients at all. So that was something I had to learn in practice. So I do think the right answer here is that you want to hydrate them. Okay, last question. A 22-year-old woman with hypoplastic left heart syndrome who's undergone a Fontan procedure presents to your adult congenital heart clinic for an initial visit. She is without cardiovascular complaints. Her medications include aspirin and lisinopril. She has a boyfriend. She's interested in future pregnancies, but not in the immediate future. She wishes to learn about potential long-term complications of her condition. Which of the following statements is true? A, in patients with Fontan physiology, hepatic laboratory studies are often not discriminative, and hemodynamic assessments do not always correlate with the extent of fibrosis and severity of disease. B, if she desires contraception, she should be started on a combined oral contraceptive pill. C, if she does become pregnant, she should continue the lisinopril to promote afterload reduction. D, she should be counseled to consider switching from aspirin to warfarin, as warfarin is associated with a statistically significant lower thrombotic event profile in adults with Fontan physiology. Or E, bosentan has been shown to improve exercise tolerance in patients with Fontan physiology and should be continued throughout the pregnancy due to its beneficial effects. Well, I congratulate you all because I actually didn't mention this in the presentation, but it is true that one of the things we're learning about adults with Fontan physiology is that it's really, really hard to understand the liver. So we can do blood tests which show normal LFTs and good-looking function, and we can even have our catheterization team do hepatic wedge, and it's always low. And yet, when you do a biopsy, they have a great degree of fibrosis. If you send a FibroSure test, they have a high score. So it is true, the answer, in patients with Fontan physiology, hepatic laboratory studies are often not discriminative, and even the hemodynamic assessments don't tell you the extent of fibrosis of their disease. Now, these other questions relating more to pregnancy, we know in B is wrong because we want to avoid estrogen-containing contraception, so that's what a combined oral pill is. And we know that lisinopril would be teratogenic, and besides that, the placenta is the best afterload reducer, so she doesn't need that. And then as far as D, we don't have evidence right now that warfarin is superior. The adult congenital guidelines state adult patients should be on warfarin with Fontan if they've had a prior atrial arrhythmia, if they have a residual shunt, or if they've had a previous clot, okay? But again, those recommendations aren't based on hard evidence. And lastly, bosentan has absolutely been shown to improve exercise tolerance, and yet it is contraindicated for pregnant women. So we would stay away from that in pregnancy. Well, I think you guys did terrific. Thank you all for your attention.